Ya Allah, Subhanallah, Ya Allah, Alhamdulillah, Ya Allah, La ilaha, Allahu Akbar, Ya Allah, Subhanallah, Ya Allah, Alhamdulillah, Ya Allah, La ilaha, Allahu Akbar.
Assalamu alaikum wa rahmatullahi ta'ala wa barakatuhu. You're welcome to another edition and the part 2 of Palliative Care of today's woman, the African Pride. My name is Hiba Farouk, and still with me in the studio is Madam Aisha Adjoa Boating Ahmed and Madam Mariam Ibrahim. You're welcome to the studio as well. We've still been here, so you are welcome to us. We've been speaking about palliative care. We've gone in depth into so many aspects. If you've missed anything, then maybe you should stay tuned because MCA does a lot of repeating, so you could catch up and then relate it to this part 2. Now, let's just, continue and pick up from where we left off. How different is, because palliative care is new to me, right? So I go to the hospital, for, a little ailment, and then I'm diagnosed, I'm treated, and I go home. What makes it different that, somebody would have to be like, I need to go for extra, an upgrade in care, in aftercare, or something to manage my pain? How different is it? How essential is palliative care? If my question, to put it in a better way.
Okay, we should always bear in mind that we can never or should never substitute palliative care for as a disease prevention or anything or treatment as critical care.
Okay.
So you only come to palliative care when there's the need for. You've done all that can be done for you, and they still think that whatever condition you had or you are having, we've come to the end of the road, and we don't want to use that word that there's nothing that we can do for you. But from that end, they feel that there's nothing that they can do to improve your quality of life at that side. So then they'll think that it's necessary for them to bring to palliative so that we do those things so we can help better. And also it should also be kind of universally accessible. It shouldn't be like just some few people who should have access to that. And so it's like we have to do a lot of advocacy to make sure that the people understand it. Preferably, we had wished that if you've identified a certain condition that you feel that this condition is not curable or something, and from the beginning we wish that we can be there, so that we go through with the person and the family, and we should know that it's also for children too. So we shouldn't forget about our children. Do you have anything to add?
Yeah, so as I always say that the traditional medicine, whoever, not traditional as in herbal, like the normal medicine, like knowing that you're sick, you've gone to the hospital and you've gone to see a doctor. The doctor's idea is just for cure. Okay, we want to
fix this
cure.
problem.
We want to fix this problem. And they look at the disease, not the person. Palliative care focuses on the person, not the disease. And we do this. If someone will say, if you don't focus on the disease, then why am I there? We target the disease, all right, but we know that the disease is attacking a person who has other challenging issues that can be affected with the presence of the disease. And so we look at the person as a whole. The person has a soul. It's a person that has a body, like your physical being, okay, and spiritually you are inclined towards somewhere. And so we look at you in that aspect. And so that's the main difference between us and if I say traditional, I have to be careful with my words, but the other side of...
So you can use the word orthodox
medicine. So that's probably the difference. And we treat patients and the family. We support the patient and the family. So as Mama Aisha was saying, that patient, that necessary. So we target our patients. If there is a cure, why not? we go for it. But if there is no cure, there's still a person that has a disease that has no cure. And so we need to look at that person in that way. And so it's not necessarily for a person who really doesn't have a disease that cannot be cured, and that we are trying to move away from it, because people think it's only for the terminally ill. So
it's a kind of therapeutic model for patients and relatives. So we take care of them in totality, as she just said. When we add all together, so we are looking for their comfort. We want to relieve them of their psychological or psychosocial issues, in the physical aspect. So we are not for cure. So if we are saying that we are going for cure, then that means we are curing, maybe you have diarrhea and we are curing your diarrhea. That one, we can easily do that for you.
So essentially, whatever, problem you're going through, whatever suffering or pain it is, they're going to manage it and try and make it better
for you.
Like as much comfort as you can have. And, you go in, for those of you who missed the former episode, the part 1, they go in spiritually, psychologically, socially, culturally, ethically.
All the things, all the
the therapeutic aspect of it, because in Ghana as a whole, or just Africa, therapy is not our strongest, hold. It's just people do not feel like it's very essential. But then I like that it was, it's brought down to so many, diverse levels, which is very interesting.
Just a minute, just to add to it, we know that the body is interconnected. So all the colleagues, like socially, this, as she said, once a person is physical body, all these aspects are interconnected. So a patient may have pain out of control, and then you can give all the painkillers in the world. The pain is not going. For instance, there is some psychological aspect or something spiritually that is, spiritually, when I say spiritual, people may take it out of proportion as in
it's not
that religious. Spirit part. It's not based religious, but spiritually as in the being, the person's being itself. The person is actually suffering in that aspect. There is probably something going on at home that needs to be resolved. That is also contributing to the pain. And so we have this model called the total pain, where we have this physical pain, we have the psychological pain, we have the social pain, and we have the spiritual pain. And so our main aim is to support our patient. Whether you come in for cure or not, we want to relieve your suffering.
I like this part a lot, because for terminal diseases, say cancer, everybody is just focusing on the physical pain. Oh, the person is in pain. Oh, let's get some painkillers. But then, obviously, it would affect it would have the person depressed. It would have families strained financially and emotionally, because they are afraid that, is this person going to leave us, in a short period of time. So it's very important that all of these things are being tackled. Wow.
The uncertainty of whether the person is going to make it or not.
Yeah, that should be a lot of weight on any family's short. And then let's even talk about how much benefit it would give. So for example, you have a child in that family. The child gets exposed to this kind of, counseling, this kind of care. The person knows that at the end of the day, there are people, no matter how bad situation gets, the person doesn't have to be sick. The person can just be an external family member. But then you know that psychologically, no matter how situations get in life, no matter how much pain you are, there's hope for, a better living or, comfort through your pain, which is very profound. I very much appreciate that. God bless you too for the works that you do for humankind. Let's talk about personal experiences on the field. What are some of the personal experiences that have struck you or has, stand out for any of you? Who would like to go first?
Go for it.
Okay, nobody knows who to go for. Okay.
It's not easy.
It's been, there's been ups and downs.
Right.
For me, personally, it's been fulfilling.
Okay.
Being able to know that, to stand in for somebody who has been put down or who has been asked that there's nothing that I can do for you,
Right.
being able to bring a smile on the faces of that person, personally for me, is fulfilling. And it has actually helped me to see life in a different way.
Right.
Because for us, we always say that one of the pillars is that we affirm life. Okay, whatever you are going through, no matter if a doctor says, for instance, at the end of life, the patient says, oh, you have about a week or whatever to go. Our main target is not the week, no, but the quality of life within that week. So there's a way that we have a slogan that goes like, we add life to your days. So we don't necessarily extend or work at extending your life or even stopping your life. But all that we are interested in is making sure that the life that you have is enjoyable. We add life, the days that you have, we have life within the days that you can live. And so we say we take a day at a time. And that aspect of palliative care has actually affected my life personally.
Yeah.
Because for me, every day is a step. It's one step at a time.
Right.
And I need to worry about the future, but I don't need to burden myself a little
Right,
because nobody knows what will happen into the future.
right.
Nobody can tell what can go on tomorrow. And I always tell my patients, nobody knows what is going to happen. You are sick. You have a very bad disease right now. I am not sick, but I might not be around tomorrow to see you. You are here.
That is true.
Yeah. So for me personally, that has been a very good side. On the other side too, you tend to get a little bit depressed sometimes, especially when you tend to get attached to your patient. And there's a lot of burnout. As we said, we try to take care of a patient holistically. Compared to some other facilities or elsewhere, they have different disciplines that come together. But here we try to work with the limited human resources.
Right.
And so you tend to be the doctor, the nurse, the psychologist, the friend, the social worker.
You turn into a family.
A family.
Yeah.
And sometimes it's burden. And you know our system, the truth is we don't have ways of just going back, sitting down, doing a debrief, and then recharging and coming back again. And so there's this aspect of burnout that we tend to experience. And I think as a team, we try to look out for ourselves. And if you don't have a team that can stand with you, it's kind of challenging. But all in all, I personally think it's fulfilling. Ready to look into my patient's face, a patient who has hours to days to live, and the person just smiling at me and saying thank you, for me is fulfilling.
It's always fulfilling. You know, we had one incident whereby this patient had the whole face, gone. But even though she has a lot of pain, but she was very grateful for us for being there, because some of them have issues with the family. Some families, either they are scared or they didn't have any good relationship with them. So they try to move away from.
Yeah, there's a lot of neglect.
Yes. So we do home care. So we do visit them in their homes and then take care of them holistically. Everything that they need to do, we did for them. Our pockets, we always, trying to help, because we had an incident whereby one child died, and the mom, before that, we have to supply them the drugs, medication, pay all sorts of things for them. So when he died, we have to go for a chaplain. We bought the coats, we bought they call suit, and then we got the coffin and everything. We did the food, everything for them. At the end of the day, they were very grateful. But you see how human beings are. At the end of the day, she came back. That we can also give her money to do a funeral rites. So we said, please, Mom, we don't have it. But some of them look at you, smile, and with all their issues, and tell you, God bless you. There was one elderly woman who, after we seen her, she has a big folder like that, and she's been through the system, going there, and she said nobody, for a whole 3 good years, nobody has ever told her that her condition is one that cannot be treated, and that she may go with it. So when she came and we did a chat counseling, we counseled her, we talked a lot about everything. At the end of the day, the woman was so happy. She told us that, Maria, in the vernacular to it that my lady, I'm very pleased and happy that you've told me about my situation. God help you. I mean, God help you and bless you in abundance. Now I know what is it. So I'm going home to prepare because I have a lot of things to do. I need to go and prepare. So God bless you in abundance. And she was happy. She knows that. She said, oh, I know I'm going to die, but I didn't know. So I haven't prepared myself. So I'm now going to prepare and do everything that I have to do before I go. Because some of them, when they leave, there are a lot of co-hosts at their back.
Right.
Yes, and some of them too, because of that, they cannot even give up the ghost, I'll say. Yes,
And some get aware that they have a few days.
Yes.
However, they're too depressed or too just spiritually
Spiritual
down
pain, yes.
to want to bother about, the things they need to do to
Yes,
leave
yes, some of
behind.
them, that's how it is. So it's very, very fulfilling. Though, as she said, we get burnout. And we don't have, because we're not many, we are not able to get the requisite holiday or going somewhere just to recreate and then come back. So, and sometimes the kind of, let's say, finances to become another issue. Yeah, because we wish and we want to help with our clients more than spending it on us,
Right.
It becomes
Absolutely.
an issue, but we are coping. We are helping each other. They used to call us the food team. So when we used to distress with food, so we could do different goodies and then bring it.
Right.
And then so anybody that comes to our team say, hey, these people, palliative people, when you go and they get food, and then you haven't been to palliative. So we started putting on weight anyway, but that is it. So our patients are very grateful.
My next question was going to have to do with challenges, but it seems you guys are putting on weight,
Exactly.
so I don't think
Yeah.
But let's. You made mention of burnout, financial strain, even on the health worker.
Exactly.
That's when people think of health workers, nobody really thinks that they're going to take out of their own, to give out to a patient, because obviously they feel like everybody pays for their bills. So, and this is very interesting to know that there's this section of people that put out their emotions, that sacrifice their emotions, their time,
their family. Because sometimes we go for home visits, we come home after 10 p.m. Even the normal regular clinic, sometimes 6 p.m., 8 p.m. before you are done. So it's kind of strained too on your family. If you don't have an understanding family, you get a lot of issues.
Right. Wow. So are there more challenges that exist? Because I can't begin to imagine.
It's like we need a place. Most of our clients, some of them have challenges taking their patients home.
Right.
They wish that, the home service that we do, we go there, some are on oxygen, some have to be dressed, the kind of food or type of food that they have is very frightening for the common man.
Right.
So we need to be going there we wish that we can have a place on our own, a place to call our own, where we can keep our clients there. For some of them want to be on admission for their last days.
Right.
So that's where we have a bit of a challenge. And our patients, some of them, you may think that, this patient has some few days or hours due to the symptoms that you are seeing or the signs that you are seeing. But we bet you see that the person can even stay 3 months. So are you going to keep such a person on the ward for that 3 months, knowing you don't know the future?
Right.
You're not got to say that, this person is going tomorrow. So those challenges, so that if we have a place of our own, it will at least help our clients and ourselves too.
Yeah. And can I add?
Yeah, sure.
Absolutely.
So, talking about the challenges, as you said, picking your money out of your pocket at a healthcare rate. This, I have to assure you, it happens in most of the departments.
Really?
The thing is, when a patient comes in, and sometimes it's not always that it happens. I think it's not all health workers who will dig into their, and some even don't have to even dig into their pockets to give. But sometimes the situation that comes, you feel like helping. And so one of the things that for me, I think helps us is our patients who, for instance, those who pass on, some leave medication, some also travel, they say, oh, I have a donation. People give donation of medications. And so we tend to give to people like that. But in some specifics where patients need that money, you just can't just look on, but just to help them. And so basically, palliative care is not a place that provides money for the hospital.
Right. Yeah, you have to put that across. You're not going to get free money from palliative care. You might get maybe extra food, but not free money.
Yeah. So money aspect with the health service.
Right.
If you want to run palliative care, because before some of the patients even come to the department or the unit, they might have spent everything that they have.
Right.
Yeah.
And so for those who can afford some of the things, it's few. Yes, and these are some of the challenges. And as she rightly said, we have different models or settings that we practice our care. We have the OPD settings, we have the home care settings, we have the ward settings, and we have we call something like the mobile hospice where the patient is all part of the home care service.
Right.
But all these services can't be provided. How much can the patient afford to bring across?
Right.
And so sometimes it's actually good when we have people who are ready to support these patients.
Right.
And that's what I like with doing palliative care on mercy ships, because I know that when I go and see my patients, even though someone is paying for it indirectly, I don't need to write a prescription and give to my patient.
Right.
I just have to go into my medication bag and give medication. And then I don't have to talk about money with my patient because he doesn't have to pay.
Right.
And for me, so that's the joy of doing work with mercy ships. Here, patient will come in excruciating pain. You see patient, you talk to patient is fine, then you write a prescription and patient says, I can't afford. Quality of life cannot be achieved with that problem. And so we try our best. So that's one of the main challenges that we have. And again, as I said, we don't have money, so the health service do not really look at our side because we don't generate a lot of money for the system. And so they don't really. So now we tried, as she said, we tried 9 years ago. It has been in the system for quite some time, but bringing it up has been difficult because we don't get the needed support that we have to. Previously, there was no training institution in the country. And so for some of us, we had to train outside. You had to travel outside and pay you some of monies to get some form of training. Not even a specialist training, but some form of training. But it is now currently that the Ghana College of Nurses are doing a specialist course to train palliative care specialists.
Right.
And then we also have the Ghana College of Physicians, the Family Medicine Department doing training to train people. So some of the consultants that we have in the country had to travel outside to get their training. So it's actually a major challenge, human resource. So if you're talking about challenges, we can talk on and on. We will not exhaust. But all in all, we still chase the challenge and we still stand and then support. Yeah.
Right. I made mention of COVID. We're still in the pandemic. It doesn't seem to go away. Sometimes we wish we could go to bed and then start from, I don't know, maybe January 1st, 2020, where there was no pandemic or no COVID-19. But now that we're speaking about pain and suffering and better conditions for people that are going through all of this pain, where does palliative care come in, and how much pressure has the pandemic brought on your department?
For our department, I'll say that it's kind of limiting for us to be able to see our patients, especially in their home setting.
Right.
Because we don't want to carry the viruses to the person's house.
Right.
Already, their immune system is low. And also, we also don't know what is in their house that we're also going to meet. One of the challenges is that we don't have enough protective personal equipment that we need to use to go home with it.
Right.
And we used to go home with a lot of staff because it's interdisciplinary.
Right.
But now, sometimes Mariam alone will go to the home visit, or she'll go with another person, you know. So it's like, it's limiting us. And then because of that too, we are not able to let them come to the hospital regularly as we used to. So when we manage to see you, then per what you have, we give you your treatment. So the subsequent reviews, we let the relation come to see us, and then we give the prescription. And then we give them all our telephone numbers. So they call us at any time. Some of them, 2 a.m., they'll call you because they cannot sleep and all that. So we just give the prescription on the phone.
Right.
And then we used to talk to, or since last year, we had a memorandum of understanding with some of the pharmacy shops where we know that they can get the type of drugs that we are using.
Right.
So that when they bring the prescription on phone, they can call us to verify.
Right.
So then sometimes they don't need to come. We just give them the phone. They go there. We talk to the pharmacist. They supply the medication. They pay for it, and then they go home.
Right.
And so now, because of that, we kind of, I would say, load shedding, or So if we have to see, say, 4 patients in a day, we limit it to 2, and because we need to give them some spacing.
Right.
We don't want them to be affected or afflicted with it, because you don't know who is having it and who is not having it. And some of them, like yesterday, a patient that we had, she came in without mask. So I said, please, ma'am, where is your mask? She said, when I put it on, she had a tumor here.
Oh.
So when she puts it on,
Right.
it's very painful for her. So I realized she was using the cloth one. So I decided to give her the disposable one. That one is lighter on her.
Lighter on the
So
skin,
I gave it to her, and then she was wearing it. Such a patient. So that means from all the way from the house, she never wore.
And she has been exposed.
Yes,
Especially with a very low immune
Yes, because she
system
didn't also
already.
come with her own transportation. She came with a general transportation.
Oh my God.
So you see how it is. It's very
Right.
challenging. And we don't want
Very.
our patients to go through such a stress.
Right. Unfortunately, we have run out of time.
Wow.
This has been very, educative. 2 things, 2 lines that struck with me from this conversation is that they focus on the person but not the disease. And another one that was very profound is that they add more life to your days, which is it's a very beautiful phrase. I've been speaking to Madam Aisha Ajua Boating Ahmed, who is the Deputy Chief Nursing Officer at the Kolebu Polyclinic and the clinical lead nurse for palliative care. I just found out that palliative care is no joke. So she's doing a tremendous job. I've also been speaking to Madam Mariam Ibrahim, who has a master's in public health and a specialty in palliative care. She also works with the Mercy ships, and she is a nursing officer. These are amazing people that are putting in their sweat, their time, their everything into helping people make their life better. People in very, very compromising positions. May Allah richly bless them. If you're out there and you're looking for, an avenue to make a certain kind of donation, please, palliative care is very in need of your donation. This has been today's Woman, the African Pride in the Wahab Adam Studios. Thank you so much, ladies, for gracing this show. My name is Hiba Farouk. I've just received a load of information which has me a bit emotional, but my name is Hiba Farouk. Assalamu alaikum wa rahmatullahi ta'ala wa barakatuh.
And there is no God beside him, the knower of the unseen and the seen. He is the gracious and the merciful God. Oh Allah, you are most great. He is Allah, and there is no God beside him, the knower of the unseen and the seen. He is the gracious and the merciful God. Oh Allah, you are most great. Oh Allah, you are holy. Oh Allah, we praise you. Oh Allah, there is no God, you are most great. Oh